So good morning to all, especially in Nadisan and giving the opportunity. And actually, the previous talk was very good. So the my job become very easy because this is the very difficult topic for me. So the my topic actually comprise of this headings. So there is no financial disclosure. So as you all know, actually the cataract surgery nowadays is the refractive surgery. So everyone want to keeping the patient is spectacle free. So, but the routine monofocal cataract surgery does not address the presbyopia, intermediate vision, astigmatism. So, so as you see, in the myopia and hyperopia can be corrected by the appropriate spherical IOLs. Approximately when we see the study, approximately 20% of the cataract patients have the astigmatism of the 1.25 diopter 2 or more, or 10% patient have the 2 diopter or more astigmatism in the preoperative. In the actually picture shows that the after the cataract surgery, they are the sometimes after the monofocal, they are sometimes the results are unsatisfied. But the toric IOL is also actually remove the cataract and astigmatism both. So management of the astigmatism, often there are the few options: the spectacle, contact lenses, and opposite clear corneal incision, and LRI, and astigmatic keratectomy, laser refractive surgery, and toric IOL. These are the highly accurate and predictable. The upper the four options are actually not accurate, but the laser refractive surgery is accurate, but they are slightly more expensive, and there are the few complications also. So they are the few indication of the toric IOL, visual significant cataract, corneal astigmatism, regular astigmatism, and correction of the astigmatism in the IOL plane. So they are the they are the many factor that are responsible for the optimum outcome of the toric IOL, like surgical induced astigmatism, and pre-operative evaluation is very important, especially biometry, and this the IOL calculation is very important, and especially in the surgical steps also, medical surgical steps also very important, and removal of the visco from behind the lens is also important, and the rotation of IOL also important. So they are the component of the this the toric IOL calculation, the axial length, keratometry, the three different devices: manual keratometry, automated keratometry, topography, and surgical induced astigmatism, and IOL power calculation. So in the keratometry, the steep and flap meridian is 90 degree apart. Multiple measurements should be taken. Key reading of the two separate devices to match, and key reading not to vary more than 0.5 diopter. So we take the minimum two measurement with the different principles, and it should be not mismatch, or it should be repeatable. If there are any mismatch, toric IOL not should be done. So every incision can change the corneal curvature. So there are the many factors affecting the corneal astigmatism: the size of the incision, location, patient age, sutures, and vary from the patient to patient. So the surgical induced astigmatism should be actually calculated for the every surgeon in the separately. So be precise about the excision, incision, and location, and the calculator auto calculate the SI excision if the fill the 20 to 30 cases in this calculator. The post-corneal astigmatism always the against the rule astigmatism. If the anti-surface is with the rule astigmatism, total astigmatism is slightly less, so the threshold should be slightly toric threshold should be slightly increased. And if the anti-surface is the against the rule, then total astigmatism more, so the toric threshold should be decreased. And there the posterior curvature measurement can be done with the OCT or pentagram. And the Bayer normgram that actually determine the effective toric IOL population depending upon the effective lens position. So IOL with the low power, deep AC, IOL with the 0.5 diopter or more toricity, IOL with the high power or shallow AC, IOL with the 0.5 or less toricity. So axial length appellation ASCN is not accurate. So they are the two technique, immersion and optical biometry is accurate, but in the mature hypermature cataract, the immersion technique is accurate, but in optical biometry, the accurate but has the limitation in the dense cataract. So according to the short and the long eye, these are formula should be actually applied. And corneal topography for the toric IOL to be avoid in the irregular astigmatism and rule out the other causes of astigmatism like scar and degeneration and ectasia. And the toric IOL calculator is ideal if the considered posterior corneal astigmatism, surgical induced astigmatism, or effective lens forward position. And there are the many calculator are available online, the Alcon online calculators, Acreol online calculator, and Barrett formula. So initially we have to put the demographic details, and then data is more important than the steep and flat axis, axial length, surgical induced astigmatism, incision location, lens thickness, and wide to wide diameter. And data input the demographic details and keratometry, IOL spherical equivalent, surgical induced astigmatism, and incision location. So data it output is the recommended IOL is model, a spherical equivalent of the IOL, and amount and axis of the residual astigmatism. So this is the online calculators available. So now that there are the many new formula are actually available, the Barrett universal seconds. These are the all formula are in the experimental phase. I think it will come. And newer is the aura is the initially talk the intraoperative aberrometry. So this is the optimize the refraction analysis and real time IOL calculation and estimate the total refraction. So residual estimate what to do actually residual estimate either after the toric IOL. So manifest the refraction the plus or minus power enter the axis current toric IOL calculate. So and they actually we calculate according to. So we conclude the toric IOL calculation it should be in the total corneal astigmatism, regular astigmatism topography, and appropriate IOL formula should be applied, and ideal online calculator should be applied. Thank you, sir.
Can you ask some questions?
Please.
So, if you do the keratometry on IOL master and a lens star, and you do keratometry on a pentacam, so how you compare and which one you take as a more reliable?
If there is any irregular astigmatism, it's not reliable, I think.
Should I answer? Okay. So there are two things. When you take a pentacam reading, it gives you the anterior surface as well as the total corneal power, which gives the combination of anterior and posterior both. So when you are comparing, compare anterior with the anterior. Do not try to compare posterior with the posterior to know whether there is agreement between the instruments or not. And secondly, when you take the astigmatism for correction, then take the total, because it will take the posterior corneal curvature also into the count. For knowing whether your data is all right or not, so compare anterior with the anterior. Anterior also between 2 to 3 millimeter, because in a pentacam 1 millimeter will give you different axis, 2 millimeter will give you different axis and a volume, 3 millimeter will give different, 4 will give different. So when you are choosing the IOL, then you should choose according to the pupil size also. That means if the patient's pupil is small, take a smaller, but usually 2 to 3. Western data takes 4 millimeter. There's another talk on this? No. So there is a Western data is usually on a 4 millimeter, which you should not take because Indian pupils are little smaller as compared to the Western pupil size. So compare and take the total corneal power for calculation. And whatever may be a toric IOL calculator, you should apply your own mind, because if the different equipments are giving different readings, then you should think of what axis are you going to place. So pentacam axis will be usually more correct. And if there is a disagreement of the two axes, then treat the patient with steroids and lubricant eye drops for 2 weeks till your data gets aligned. Most of the time, the pitfall is dry eye, uneven corneal surface.
Sometime when IOL master or you measure when the dilated pupil or undilated, so there will be a slight difference in the IOL master's K reading data or calculation. So best is to calculate on undilated or normal pupil. And if you are measuring that with the IOL master, there is a high astigmatism or some unpredictable astigmatism, then you should definitely compare it with the topography.
Different machines measures the cornea at different size. For example, autograph with K measures at about more than 3 mm.
Yeah.
Whereas Lenstar, if you go, it is 2.5 mm. With IOL master, it is 1.5, 2.5, differently size.
So
We cannot compare three machines as the same, but magnitude should be same. That is the aim.
So once the main problem comes in the astigmatism.
Yes, sir.
So that vary from 2 mm, as Dr. Harbans mentioned, it vary with 2 mm. So ideally it is 2.5 to 3 mm for the Indian people, and you should take it from the topography. Topography will give all the astigmatism from all the range, because IOL master, whatever they fix, 2.5, 3 mm, Lenstar, whatever they fix, there is a fix, you cannot change. Topography you can compare and then you can adjust that data.
So topography usually gives sim K, and we want for the cataract the central most corneal curvature.
At 3 mm.
Central most, sir. Because for example, Varion, if you take 1.2, it measures. So it will be more steeper because cornea is steeper in the center and flatter in the periphery. So the keratometry varies in central point. As it goes periphery, it will become more flatter and flatter.
No. I think when you are comparing, you compare, like I told you, because your lens size taking 2.5. On a pentacam, you compare 2 and 3. And particularly, axis, if you will see at 1 millimeter, it is the total refraction which is important. It is not, when you are talking of the RK, irregular cornea is entirely different, because there is a more flattening. In a regular cornea, usually pupil size should be your guide. That means pupil size is 2 millimeter. 2 millimeter will be better than taking 1 millimeter, because 1 millimeter is too small. And most of the time, what I have found, the axis acceptance with the refraction, and refraction is very, very crucial. What I am now noticing over a period of time, I didn't want to bring up this topic. Many patients do not have a keratometric astigmatism, but when I put on a normal monofocal, next day we find that patient has got a cylinder of 1.5. When I go back and analyze my data, patient was using actually spectacle prescription on that. So why it is happening, I don't know. So the axis agreement with the spectacle prescription, with the pentacam, and on the biometry. So if you get all of them, that means you are very, very dot on. But if there is a disagreement, then take refraction also into the account. What is the, when I am finding there is a disagreement between the pentacam and a biometer, then I look into the patient's refraction, what he is accepting on the refraction. Then probably I'll give the weightage to the refraction and accordingly adjust what I want to do.
So Dr. Harbans, that means for a person whom you're calculating a toric IOL calculation, you're doing calculation, you're putting the patient through so many.
Yeah.
Otherwise, normally we are doing it with just IOL master and then determining. That means our results are probably inaccurate. I mean, thanks. That's great information.
Yeah.
Probably if the patient is emmetropic and your topography is showing astigmatism, then you should definitely consider the topography, because this astigmatism might have balanced by the lenticular astigmatism.
So topography usually gives sim K values. It takes the average and it gives a sim K.
No. Topography is a value when it gives 1. It is a 1 millimeter diameter value. It does not take, when it gives a 2 millimeter circle, what is the estimate? It does not give the total of 0 to 2. It gives the estimate at 2 millimeter. So it is not the sum of the, if you take a 4, it is not sum of the 0 to 4. It is at 4 millimeter what is the astigmatism. It is not the sum of all of them.
So then why not the keratometry of the topography is accurate? Should be used in all the formulas?
No, because the astigmatism, like if you see the hill, so it's not the same. Apex, that's the reason, in spite of sometimes totally haywire toric IOL, and you get a very good results. Because there's some point is getting corrected. If you see the RK patients, they have got so much distorted cornea, but still they are not complaining. Or there is some point in the cornea which is focusing the image for him. But we need to compare all the available instruments to be more sure and confident what we want to do. And always promise a patient that the vision is best if your astigmatism is less than 1 diopter. So we do not promise 0. And this is very easy target to achieve. And most of the time you will get 0.5% residual you will get, but most of the patients are very happy. Even if, and I think this
Sir,
discussion will go on, so I will
yes, we are running late.